Hello everyone, welcome to the Bacterial Infections lecture. So this lecture is designed to take the content from the first lecture, which really just talks mostly about the drugs and their coverage and kind of touches base on some of the things they're used to treat. Doesn't go into too much depth on this, and this is really talking about infectious disease from a review of systems perspective and how we treat things, what's first line, that type of stuff. So from a clinical perspective, this is much more important probably if you want to look at it that way. At the same time, you have to have the foundational stuff down, so you have to know the drugs first, of course. So infectious disease is probably one of the more complicated topics when it comes to pharmacology, and certainly there's a lot of antibiotics, and I understand that it's difficult when you start out right away. You're trying to learn drugs and drug terminology and all that stuff, and then you're kind of thrown into ID, which is has a lot of applications throughout multiple different systems and diseases. So I think the core concepts we'll talk about are going to be repeated throughout this lecture. So hopefully you kind of get a feeling for what I'm looking for, how I think about infectious disease, and how I apply antibiotic therapy to patients. During lecture this week, we'll talk a little bit about that in person and kind of give you a chance to answer some questions. But this lecture is designed to apply the knowledge from the previous one. I get a number of questions all the time, basically, about people asking, can I have more sample questions? Can I have more practice questions? That kind of stuff. I do have sample questions that I post from time to time. Sometimes they'll be in a PowerPoint or a Word document as an example towards the end of the module, like before an exam. Other times they're embedded in the lectures. I sort of do it both ways throughout the course. I try to do a handful for each module. You won't see me releasing really large quantities of them, and I know everybody probably wants more questions, but to me that defeats the purpose a little bit. I know, bear with me for a second. I think the idea here is that we're trying to teach you the concepts here and have you be able to go into a case on an exam and be able to apply those. And of course, it's a multiple choice question, so not really like real life, but at least I can give you a feeling for how I'm going to answer questions or ask questions. So here's an example of what I might ask based on the last lecture. So this is which of the following combinations would be reasonable to start if your goal is to provide broad spectrum coverage, including possibly resistant gram-positive, gram-negative, and anaerobic bacteria. So whenever I say possibly resistant, you can assume that would mean you would want to cover things like MRSA, which would fall into the resistant gram-positive category. Resistant gram-negative would be like the Pseudomonas coverage. Remember we talked about using Pseudomonas as sort of the general catch-all for those resistant, hard to treat gram-negative bugs, and then anaerobic coverage. So this is really the most broad spectrum you're ever going to start anyone on. So if somebody comes in septic to the hospital and you don't know what the source is, you're going to probably treat them with this type of a cocktail. So I'll give you a second to think about the answer and go through these choices first. So cefazolin plus primaxin. Primaxin covers two of the three categories. It covers gram-negative and anaerobic bacteria. Cefazolin covers gram-positive bacteria well, but it doesn't cover resistant, so it doesn't cover MRSA. So A would be wrong. So what we want for our resistant gram-positive coverage is something with vancomycin in it, probably, for a first-line option. So vanco is correct here. Linezolid would also cover resistant gram-positive bacteria. It's just not a first-line option. It'd be like a second or third-line option. So it's not wrong in the context of this question, but the second part here is. So azithromycin is really just used for atypical coverage. We don't really use it for much else in the antibiotic world. So you're between B and C, and between these two, Zosyn or piperacillin tazobactam is going to be the more broad spectrum. It's going to cover more resistant pathogens. It's also going to have anaerobic coverage. Ceftriaxone is a really great drug. It's fairly broad spectrum. It just doesn't cover Pseudomonas. It doesn't really have appreciable anaerobic coverage. So B is the correct answer here. Which of the following medications would not be appropriate for an infection caused by Pseudomonas? So you get the feeling that I like this. This is important. Hopefully you're getting the message here. So I'll give you a second to pause and answer. So everything on here covers Pseudomonas except the one I just said, which is ceftriaxone. Okay, based on the patient below patient allergy information, which of the following antibiotics would be least likely to cause an adverse reaction? So this is something that you might see on a patient chart, and you're trying to decide antibiotics. They report penicillin hives, cephalosporin rash, and fluoroquinolones tendon pains. So if you were going to try to prescribe them something, what wouldn't fall into one of those categories? So really what I'm looking to do is have you match up the class to the specific allergy. And in real life, you might investigate some of these. You might say, well, did you really have a rash to cephalosporin? Have you tried this or this or this? Or you might, dig into the chart or have pharmacy dig into the chart and see if there are any specific drugs that they've tolerated in the past. I get asked to do that almost on a daily basis. It's a really common thing that comes up for me personally. Apparently, I have superhuman abilities to look at medication history in the chart. I don't know. I think I just know where the right filter buttons are. And for whatever reason, providers don't have as easy access to that kind of stuff. So with that aside, the question, again, I'll give you a second to pause if you want. And the answer to this is going to be B, doxycycline. So doxycycline is technically a tetracycline as a class, and that doesn't have any cross-reactivity to any of these. Cipro is a fluoroquinolone, cephalexin is a cephalosporin, penicillin, or augmentin is technically a type of penicillin, or a beta-lactam, if you will. So with this, again, does it, if you had to give a cephalosporin and they had a rash to it in the past, does it really matter? It depends. Probably, maybe not. But this would be the easiest, the path of least resistance, I call it. So you're picking doxycycline because, well, they've never had any reaction to this that's documented. So let's just do that and not have to worry about, trying to challenge one of these things, which can get complicated. And we'll talk about that, or I talked about that in the last lecture a little bit about the allergies and how we do that and how that's challenging sometimes. But so that would be one way to do it. Now, again, I didn't give you any context here, so this maybe doesn't make sense, but you get the idea, right? You look at allergies and, you can go one of two pathways and say, all right, I really want to prescribe augmentin. They have a penicillin hives allergy. Was it childhood? Have they tolerated anything since then? What are the options here? Or you're just going to say, I'm not going to deal with it. I just want to find something that the patient hasn't had a reaction to at this point. And then, you pick based off of that. Okay, so one of the most important things to think about with infectious disease is just the thought process behind how we arrive at the antibiotic choice. And that has to do with a lot of different things. And this slide is my attempt to summarize that. So your source of infection, different sources, different drugs sometimes. Now, a lot of our drugs work for pretty much all different types of sources, but some drugs, for example, just don't concentrate in the bladder enough to treat a urinary tract infection. Some drugs don't penetrate the central nervous system. Some drugs don't get into the lungs very well. And so those types of things are important to consider when you're thinking about which medication you're picking. Common pathogens. So when you identify your source, let's say it's an intra-abdominal infection, well, then you're going to be treating something anaerobic potentially. So Bacteroides is a common one. You also want to cover your gram negatives, E. coli specifically. So just knowing that source can help you identify what those common pathogens are. So those are things that every provider for the common infections really has to have down pretty or have readily available in your immediate memory recall. You have to be able to think about this stuff and say, okay, well, this is the source infection. These are the common pathogens that do that. And then you can match up the drug to those two things. That's really all you need to do. Now, those are the big three. Those are the big two you're going to use to make your decision. Now, the second and third and fourth, or the third, fourth, fifth, sixth, seventh things on here are also really important and are probably the reasons why I might reject a choice from a provider. So looking into these things before you enter an order, whether it's outpatient or inpatient, doesn't matter. Still, it could come up. So let's say you enter an order for ciprofloxacin for somebody's urinary tract infection, and I look on their chart and say, well, they actually had a UTI a month ago and it was resistant to fluoroquinolones. So I might page you or call you and say, hey, just so you know, do you want to try changing that? So that's something that you can think about. Recent antibiotic use. Did they take that specific antibiotic? Were they exposed to that specific antibiotic? Have they had a history of that, or was it just kind of a one-off thing? So that's sort of hitting 3 bullet points in one, but you guys kind of get the idea here. Those are the types of historical things you might think of, or Sometimes you might see like, to flip it a little bit, you might see a culture months ago that says, hey, it was sensitive to everything. This actually happens every once in a while where somebody comes in and they have recurrent symptoms and their previous culture shows it was sensitive to what we gave them and it just didn't work for whatever reason. So in that case, we might not want to repeat that. Happens a lot where for some reason, sometimes that history point with the culture history or the previous antibiotic or what they were exposed to might have been ignored. Tissue penetration, we talked about that a little bit during the last series of slides. That's certainly important for certain things. For example, the big ones I remember, like daptomycin, does not get into the lungs. So if you want MRSA coverage in the lungs, you're going to have to stick to vanco or possibly linezolid. Certain drugs don't penetrate the CNS as well. Some drugs only really work in the urinary tract. So we talked about those specific ones last lecture. So that's, of course, important. Allergies, just gave you an example of a question where that comes up. Again, this is something that as a pharmacist, I get quite a few questions on fairly regularly, or not necessarily questions even. I might just notice it when I'm verifying something or confirming an order that there's some sort of a reaction to this in the past and the provider hasn't documented on it. So then I have to contact them, discuss it, and then document if we're going to go ahead and give it or try and find an alternative for that person to use. And of course, infectious parameters, which is going to help with your diagnostic criteria at the beginning, but certainly a role in all this. Is it really infectious at all? That's a good question. Okay, let's start with skin, soft tissue, and bone infections. Cellulitis is probably one of the more common things you'll see throughout the spread of medicine. So whether you practice in urgent care, emergency, inpatient, outpatient, you're going to see cellulitis. Cellulitis is really just kind of a skin infection that's gotten really bad. Usually you see, if you're not familiar with these terms, sorry if I'm being a little, I'm not trying to talk down to anyone, but I just don't always know exactly what you've had before. But cellulitis is kind of hallmark effects are going to show red, swollen, hot. Sometimes people draw markers around the area to see if it's getting bigger or smaller. That's a way you can kind of see how much it's progressing. Facial cellulitis or periorbital cellulitis can happen too. That sometimes is a little bit trickier to treat than your standard run-of-the-mill cellulitis. Fortunately, cellulitis is usually caused by one of two different bacteria, Staph aureus or Strep pyogenes. And so our go-to drug is going to be cephalexin or the IV form, cefazolin, if you want to give something IV. Basically, any cephalosporin is going to cover this. So you could give, like, let's say you wanted to expand the coverage. A lot of times I talk to providers and I'm like, oh, I want to treat for cellulitis, but I'm concerned it's kind of a gross infection. Maybe there's some gram-negative stuff in there. What should I expand it to? I always recommend maybe trying ceftriaxone in those cases because that's going to add some gram-negative coverage. And at the same time, you're going to still retain the gram-positive. So most cephalosporins are going to have pretty solid Staph aureus and Strep pyogenes coverage. Now, of course, MRSA is a gaping hole in the cephalosporin spectrum. So that's something that if you are going to cover for MRSA, you're going to have to switch it up. And so the basics behind treating for MRSA or empirically treating for MRSA. So let's say you have a cellulitis and you don't know what it is. What you're going to look for is purulent drainage and recent exposure to MRSA. And then the PO options for MRSA are going to be clindamycin, Bactrim, which is sulfamethoxyl trimethoprim, doxycycline, and linezolid are all options. I almost tell people to kind of ignore Clinda. It's just something that doesn't have very good coverage on the baseline for MRSA. It usually has about a 60 to 70% coverage rate of any type of staph, whether it's MRSA or MSSA. And so the odds of you covering it right away is about a 2/3 chance. And that's just not good enough for empiric coverage. Usually we want at least an 80% rate. Ideally, you want in the 90s. So I don't ever recommend people use Clinda empirically for any type of skin and soft tissue infection. The only way you'd want it, the only time you'd use Clinda empirically is if you had no other choice. Like if somebody's allergic to everything else and you have to do it, then that's fine. Just know that a lot of cellulitis is going to be caused by a Staph aureus, whether it's MR or MS. Would be determined by culture, but Clinda is not a good choice for MRSA empirically. Now, if you get a culture back, let's say you started somebody on cephalexin, and it comes back growing MRSA, and it's sensitive to Clinda, then you know it's sensitive, then you can go ahead and switch them. That's not a big deal. But empiric therapy with Clinda is really risky. So Bactrim and doxycycline are the two most common ones prescribed for MRSA. I'd say Bactrim is probably the most common for that particular one. Sometimes I do see providers do a combination prescription. So that's where I have this. So they may pick an MRSA agent plus cephalexin. Sometimes they'll prescribe Bactrim and cephalexin, have the person start taking it, and then when the culture comes back, so maybe they drain some fluid out of it, culture it. When it comes back, then they call the patient and say, hey, it's MRSA, you can stop the cephalexin. That's the important thing if you decide to do that. Well, first of all, you might be wasting the patient's money because they paid a copay, or maybe they paid cash for the prescription, so they might not be really happy with you. Otherwise, it's a little inconvenient, to have to call them and make sure. And then what if they mix it up and they stop taking the wrong one? So there's chance for confusion there. If you are if you have these criteria met, you can probably safely just prescribe Bactrim right off the bat. And if you don't, and you're kind of on the fence and you want to prescribe cephalexin, make sure you get a culture, follow up on the culture, and then you can change it, if it comes back MRSA. It happens all the time, so don't feel bad about it by any means. If you prescribe cephalexin and it comes back MRSA and you have to change it, again, that happens a ton. I do this. I follow up on cultures a lot as part of my job in our emergency department, and it's just nature of the beast. Combination therapy, again, you could try really any of these if you wanted to start out that way. I'm not, and just to be clear, I don't want to say that combination therapy is like the standard by any means. Most people don't do that, but again, there are some providers that in certain situations feel more comfortable prescribing for covering both MSSA and MRSA right off the bat. Incision and drainage, if something is an abscess, that's really the best treatment for it. So especially if you work urgent care, ED, or maybe even in clinic for smaller ones, you're going to do a lot of INDs on these things, and that's going to take care of the majority of the problem. A lot of times what I think about giving antibiotics for is, let's say you do an IND, it goes well, you pack it or whatever, you dress it appropriately. You might prescribe some cephalexin to prevent any surface, bugs from getting into that open wound and reinfecting it. So you don't want whatever is on the skin to reinfect it. Certainly, you could culture that. I would culture that fluid you're pulling out of the abscess and make sure that there's nothing odd growing in there. And then you might want to tailor your coverage just to make sure nothing is regrowing. But generally speaking, a good IND is enough. But most people will cover with antibiotics just either prophylactically to prevent a regrowth of a skin bug from getting in there and kind of having an opportunistic situation, or they will culture and then kind of tailor from there. Treatment like for cellulitis is usually 7 days up to 10 days if you wanted to. Some other considerations, here's my goofy pictures. Puncture wounds, you have to consider the location, what punctured the person, where was it, did it go through somebody's shoe, was it in water? That all might make a difference. Why does that make a difference? Well, water has weird stuff in it, like Pseudomonas likes water, for example. So you might have a cellulitis from a pseudomonal cellulitis, which is kind of odd to think about, but it happens, especially with a puncture wound that's been in water. There's a lot of other odd things that grow in water too that you might see on a culture that you wouldn't see on another thing. Something that goes to the bottom of a shoe might get dirt or some, again, water, gram-negative stuff. I think about was there something on it? Was it like a really dirty tool that somebody was using that ended up, cutting them pretty deeply? Those are things to think about. Do I need to prophylax for the particular item that penetrated this person's tissue after you repair the laceration? So that's just something to consider. Usually I just recommend people stick to kind of basic coverage unless you know for sure. If you had somebody step on something sharp underwater and get a really nasty cut and you wanted to prophylax, something like Cipro is a good option because it covers your gram-negatives pretty well. It covers Pseudomonas. It covers some of the other weird water pathogens that sometimes show up. So that's a nice choice if you were concerned about that particularly. But certainly there's the option to culture the wound as well and see what grows, and then add therapy afterwards. But it might be a good move, especially again if it's a really bad wound and it was underwater. I would recommend considering at least some gram-negative coverage in addition to your cephalexin or whatever you're going to use. Animal bites and wounds. So basically any animal bite and wound, including a human bite, is going to be covered by Augmentin. Augmentin covers a little bit of gram-negative species, especially ones that tend to grow in mouths of animals and people. Excuse me there. Dog bites, cat bites, different bacteria potentially, different duration of disease and severity, but overall it's going to be the same treatment. So I always ask this question, what do you think is worse, a dog bite or a cat bite? And almost every year everyone gets it right, or whoever answers, I should say, gets it right. A cat bite is going to be worse. So cats have sharp, pointy teeth that are small and they can get really deep into tissue on a solid bite, whereas a dog's teeth can cause more surface damage but tend not to infect as much. So like dog bites, I think I was reading it's 5% infection rate, whereas like a cat bite untreated, and this is untreated, a cat bite untreated, like 95% will get infected. So that might lead you to treat somebody empirically versus not. I wouldn't say don't treat dog bites. I'm not trying to say that at all. A lot of people do just because you don't really know for sure. But certainly treat a cat bite. I would definitely treat cat bites. Human bites, usually humans aren't biting each other all the time, fortunately. But sometimes people punch each other and their hand might hit somebody's tooth and get a pretty nasty cut in it. And that can be a situation where you might want to prophylax there. The Sanford Guide that I mentioned in a different lecture is a really great reference. It has a lot of different animals, from exotic stuff to more common stuff, bats, etc. But generally, if you go through it, you'll see that basically every animal bite out there is Augmentin as your first line. Second line is usually doxycycline. I don't have that on there, but I can write it in here, doxycycline, just in case you're wondering, like, well, what if they have a penicillin allergy? Well, doxy is usually the backup option for a bite. Okay, so the granddaddy of all skin soft tissue infection is the diabetic foot ulcer. So this is usually caused by somebody who has advanced diabetes and advanced neuropathy. So they get some kind of a wound on their foot and they don't feel it, so it gets worse and worse and worse until it looks something like this. It's usually really deep. The tissue is usually somewhat necrotic. It's usually very malodorous. There's lots of bugs in it of different kinds. So if you swab and culture this, you're going to get a ton of different stuff growing, which is always kind of interesting. But the point is that this is polymicrobial. So you have gram-positive, gram-negative, and anaerobes. And you're going to treat it broad spectrum. So until you know exactly what you're dealing with, and again, if you culture this, you're probably going to grow so much junk, you're going to be throwing the kitchen sink at this person anyway. So MRSA coverage, Pseudomonas coverage, anaerobic coverage. So example, vancomycin, vancomycin, metronidazole, vancomycin, those are all good options to start with. Now you could always narrow. So let's say you culture it and hey, it's only growing MRSA. Well, maybe you could try just vanco. The other challenge with these is sometimes these areas just aren't well vascularized, so it's difficult to get antibiotics in. So sometimes these patients end up needing to go to maybe get their wound debrided or go to surgery or get even like hyperbaric oxygen chambers for really bad wounds as well. So there's lots of different stuff like that. Bone involvement can of course happen too, and that's where we move to the osteomyelitis section. Osteomyelitis is really similar to skin soft tissue infections, but it's basically just a longer course. And usually you start with IV. A lot of times, because these courses are so long, the patient's not going to be in the hospital the whole time, so usually they'll start IV, try and switch them to an oral regimen. If oral can't be done, they can still be discharged, but usually you're looking at like setting them up with a home infusion or coming into an outpatient infusion center so they can get their IV product. And again, long treatment, so 4 to 6 weeks is common. Usually you're empirically covering MRSA initially until you know. You can do a bone biopsy to actually see what's growing. That's sort of the gold standard for diagnosing osteo. Agents with good bone penetration, I've listed them here. There's nothing really too surprising here. There's very few drugs you can't use. Generally, the bigger, bulkier, like beta-lactams aren't as good. So things like Primax and imipenem, Silstatin, piperacillin, tazobactam. Those are a little bit bigger molecules that just don't penetrate bone tissue quite as well. Smaller cephalosporins like cefepime do quite well, so that's a better option usually for these patients. Dermatologic, you might be wondering, well, what about the topical system? You can certainly use bacitracin, mupirocin if the laceration is small, or you think an abrasion, could use prophylaxis while healing. Acne is sort of a separate entity in itself, and we'll talk about that during the dermatology lecture, which will be during the early part of the spring semester. Okay, moving on to ear, nose, and throat. ENT infections, so you've got sinusitis, tonsillitis, ear infections, pharyngitis, ophthalmic infections, and a lot of other stuff that can happen. There's really a group of standard organisms that applies to basically all of these infections. That's going to be one, viruses, first of all. So most of these things are going to be caused by viral sources. So antibiotics for anything ENT is always a little bit of a gamble. You don't necessarily know if the patient really needs it, but sometimes the diagnosis can be really tricky. From what I understand, not that I do that, but it can be difficult to know really if you've got a firm diagnosis of bacterial versus viral. Bacterial-wise, you're looking at 3 different pathogens that are the most common. You've got strep, pneumo, Haemophilus influenzae, and Moraxella catarrhalis. So walking through these, a couple of them anyway. Rhinosinusitis is really usually viral. It's the common cold. Very few will get bacterial co-infections. Basically, you could treat it, and I've got the treatment choices here. It's a 5 to 7 day course. Usually Augmentin is what we try to, and then there's some options if somebody had allergies or something like that. About 90% of people that report to a clinic with rhinosinusitis will actually get antibiotics, and that's probably a bad thing. I'll just say that, a little bit of a soapbox, but I think we definitely overprescribe for this type of thing. Now, if somebody had symptoms, going on 2 weeks, or maybe they had symptoms that resolved at 10 days and then kind of came back worse maybe a few days later, that could certainly be bacterial. But there's a lot of debate and controversy over prescribing antibiotics for this. But at the same time, I do get that it's difficult to tell them apart, and you've got a patient who is kind of demanding something, but certainly it's worth holding back. We do want to be good stewards of our antibiotic resources, and this is an area where we're pretty bad overall as a health system in the country, and we could be better. Tonsillitis, pharyngitis, this is where strep throat comes into play. So group A strep is usually the primary culprit here. If you culture the throat, you might see group C and G strep. Group C and G strep are usually normal flora in the upper respiratory tract and usually aren't indicative of a specific infection. Sometimes they can overgrow a little bit and cause problems, but generally speaking, let's say, so the way this works, in case you're wondering, is usually you do a rapid strep test. The rapid strep test comes back positive or negative. If it's positive, you probably just treat the person with penicillin or amoxicillin or something, one of these options here, send them on their way, and you don't get a culture because it came back positive. Who really cares at that point? You know what you're dealing with. If it doesn't come back positive, a lot of times what it does is it automatically reflexes to a culture. So you culture the throat, culture comes back in a day or two, and it says it's growing group A strep. Well, great, group A strep. You have strep throat, your rapid came back negative, but your culture grew group A strep. We're going to go ahead and treat you with penicillin or amoxicillin. Now, it gets trickier when that culture comes back growing something else. So group C or G strep, a little controversial. The rule of thumb, I think, is that if the patient, so if the culture comes back in a couple days, patient is still symptomatic, I would probably recommend treating them. If If they aren't, and it's growing group C or G, I would not treat them at that point. The question follow-up might be like, well, what if they're growing group A strep, and it's 2 days later, and it comes back on the culture, and the patient says, hey, I feel much better. Should you treat me? Probably not. A lot of adult patients will resolve without treatment. Most people recommend to treat kids regardless of how their symptoms are doing. The other thing to think about too is it might still be slightly contagious even if the person's symptoms are resolving. So the antibiotics can help suppress the growth and therefore decrease the spread to other people. So there's another consideration there. If you have a more of a tonsillar involvement, it can have some anaerobic or atypical pathogens. Clindamycin and clindamycin is good for mouth type anaerobes. Remember, that's kind of the above the waist anaerobes, and then azithromycin is good for atypicals. Above the waist. That's what they always said in school. I more think of it like above the diaphragm, like mostly like upper. Actually, mostly oral flora is like what I would think clindamycin is most beneficial for when it comes to its anaerobic coverage. Otitis media, control your pain. 2 strategies. A lot of times this resolves in kids within 48 to 72 hours. But a lot of people get immediate antibiotic treatment as well. There's no real right way to do this. I think if your patient's parents usually, because this is usually a childhood thing, are willing to let it wait, that's not a bad idea. So just observe, see if they're getting a fever, if it's getting better, those types of things. Really the same bugs as adults, same treatment. We're looking at amoxicillin. Topical therapy, sometimes they might give eardrops especially if the tympanic membrane is ruptured, and we're usually looking at a fluoroquinolone eardrop. There's Cipro eardrops, moxifloxacin, things like that are available. Okay, conjunctivitis also falls under that bacterial versus viral debate that we all love so much. The bugs are the same. They're those upper respiratory bugs, but basically Staph aureus for adults might be something you add on. Mostly treating this topically. The eyes systemic antibiotics, it's not that they don't necessarily get into the eye, but it's much easier to use topicals because it's going to flush everything out and really spread throughout the area where the actual infection is, where antibiotics might not necessarily, or systemic antibiotics might not get there quite as well or as fast. So we're usually using like an ointment, like erythromycin, polymyxin, trimethoprim drops. These are both really old, cheap treatments that work well. The fluoroquinolone drops are a little newer, a little more expensive, not necessarily first line, usually for a resistant case or if somebody has allergies to the other products. Or, Pseudomonas. If somebody has contact lenses, Pseudomonas is a possibility due to contact solution possibly growing in there. And so that might be one for that particular patient population. All right, switching gears to respiratory, pulmonary. Pneumonia, probably, again, in the bucket of things, one of the more common things you'll see, generally speaking, from hospital presentations to clinic to urgent care, etc. There's 4 types to consider. Community-acquired pneumonia is probably the most common one. And then this second one is really not a term that exists anymore. It used to be called healthcare associated with pneumonia, which was sort of like, well, you got a pneumonia associated with some aspect of healthcare, which was really vague and no one really liked it because it didn't really make any sense. So they kind of took that out and they merged the two. So they basically said this equals CAP. There's no real difference between how we treat HCAP versus CAP. So HCAP doesn't exist anymore technically. You might hear the term thrown around, but guidelines have eliminated it. Hospital-acquired pneumonia is exactly how it sounds. It means you didn't have a pneumonia when you went into the hospital, and now you do. Congratulations. Usually associated with some sort of resistant pathogen or what we call nosocomial pathogens, so hospital-acquired pathogens. Ventilator-associated pneumonia is, again, just like it sounds. For people on long-term chronic ventilation, they're at high risk for pneumonia, and there's it's similar to HAP because you're looking at a hospital-acquired bug in that case. CAP is treated less aggressively, and VAP or HAP is usually more aggressively because you're usually looking at more aggressive bugs that are going to get into the hospitalized patients, opportunistic bugs, pathogens that are resistant, things that have been exposed to different drugs before, stuff we don't like. Whereas community-acquired is a little more straightforward and predictable with what kind of bugs we're going to see. Okay, oops. Wrong direction. There we go. So what are we seeing during community acquired? Strep pneumo is responsible for a vast chunk of your CAP presentations. That's a must cover. So strep pneumo should be top of your list for culprits for any CAP. Respiratory viruses, of course, can cause a co-infection, or can be the original infection, then somebody gets a bacterial infection. But again, we don't really care because we're treating a pneumonia specifically that's going to be bacterial, and we probably can identify that via imaging and things like that. H. influenzae is another really common one, and then atypical pathogens are the other common cause. I have heard different stories from people that you can diagnose somebody as an atypical only pneumonia, that maybe some imaging might show that somebody just has an atypical pneumonia, or if somebody is relatively healthy but they have a pneumonia, so maybe this is like an outpatient clinic type scenario, they have some pneumonia symptoms but otherwise they're relatively healthy, what they call a walking pneumonia, whether that's atypical. There's actually no evidence that any of that is true. There's no evidence that you can tell a pneumonia what the pathogen is from a radiograph. That's not proven. There's no evidence that somebody who is less symptomatic is atypical. So there's some debate about that, but for the most part, the point is that don't just cover atypicals. This is going to be a big recurring theme I'm going to say in the next few slides. You always need to cover strep pneumo. So any treatment you pick for community-acquired pneumonia should cover strep pneumo and your atypical pathogens. All right, so this always gets people a little confused, but I think I would recommend just kind of sitting down with it and breaking it down a little bit. Remember the core concept here with community-acquired pneumonia: strep pneumo, atypical pathogens. So going through the guidelines, if somebody is previously healthy with no antibiotics in the past 3 months, you can use azithromycin, but the big caveat here, and I say this bigly, I say this with exclamation marks and bolding. Whoops, oh, that didn't work. I already had it bolded, I guess, so it doesn't really look bold. Anyway, this is important. Here, I'll underline it. Does that work? There. So do not use if your local resistance to strep pneumo with azithromycin is greater than 25%. There is no documented place in the United States of America, and most of the world, I should say, that has a coverage rate of strep pneumo with azithromycin better than 75%. So this is basically a no-go. So let's just get rid of it, right? Don't use azithromycin, and I repeat this, I don't know how many times I can say, never prescribe someone azithromycin by itself for pneumonia. Don't do it. I've seen dozens, probably more than that, of people come into the ER with really bad pneumonias because somebody in the outpatient world prescribed them a Z-Pak or azithromycin for their pneumonia. It doesn't work like that. Don't do it. It doesn't cover strep pneumo well enough to work. That's not necessarily a soapbox, it's simple truth. So don't do that. It's against the guidelines. It's against all ID recommendations, but for some reason people in the community still like to prescribe Z-Paks. I don't know if it's because it's easy or what, but get that in your head right now that that's not appropriate. Doxycycline is a pretty decent choice. It covers atypical pathogens. It covers strep pneumo. Strep pneumo coverage isn't quite as great as some of these further down options, but it's pretty good. And if you have somebody with no real comorbidities and they're relatively healthy, it's a good option to start with. The other thing I really like Doxy for is it doesn't interact with drugs quite as much as medications like the fluoroquinolines do, and azithromycin does as well, especially like anticoagulants like warfarin, which we'll talk about in a month or two. That's one that you don't want to fluctuate too much. It can cause bleeding if it does. So there's some examples out there, but doxycycline might be situationally useful. I don't see it used very often for this, but it is an option there. Otherwise, so again, doxycycline is your option. Otherwise, you're going to treat like this. This bottom section is really what we're going to see on a regular basis. Fluoroquinolones, levofloxacin or moxifloxacin, are considered the respiratory fluoroquinolones, and those are going to be the ones you see used pretty much the most commonly. Levofloxacin is a nice option because it's once daily and it's only 5 days when you dose it at 750 milligrams a day. Oh, by the way, I don't think I've said this yet, but I'll never test you on doses unless I specifically say so, and I will make it very, very clear. There's only like 2 or 3 times in the semester I'll actually ask you to remember a dose. It's not very common. So the point is, don't remember 750, but it's here for your reference. Levofloxacin is not without its risks, and fluoroquinolones are a little bit controversial in general because there's a lot of resistance to them. Yada, yada, yada. The point is, it's a really common option because it's so convenient. Once daily, 5 days, and you're done. There's nothing else like that within these options. So the probably more, I don't know, infectious disease correct option is azithromycin plus, you can ignore doxycycline. People usually don't combo doxy unless you have like a azithro allergy. So you want to cover your atypical pathogens. And the way to do that, if you remember back to last lecture, you basically got 3 choices here: fluoroquinolone, macrolide, or tetracycline. And so your fluoroquinolone, azithromycin, doxycycline, those are all going to cover them. So here we're going to use azithromycin to cover your atypical pathogens, and we're going to add on your 2nd or 3rd generation cephalosporin, something like ceftriaxone, ceftriaxone. It doesn't really matter which one, they're all going to cover strep pneumo quite well. Or you can use augmentin or high-dose amoxicillin in place of that, and that's going to give you your strep pneumo coverage. So again, the point is atypical plus strep pneumo coverage, and that's going to give you that. Interestingly enough, if you look at like European guidelines, especially I think British guidelines specifically, they don't even cover atypical pathogens initially. They'll just give like amoxicillin, I think, as their basic cap treatment. So kind of a different course of action than what we take. 7 to 14 day course, again 5 for levofloxacin, otherwise you're looking at 7. 10 days is pretty common for cap. Okay, so if somebody goes into the hospital, this gets a little more complicated, but essentially it's the same thing. You still want to cover the same bugs, and the only time it gets, and I'll let you guys review this, I'm not going to read all these things off the slide. It's all here and spelled out, I think, pretty correctly what you can do. And I don't think there's any surprises here. The only time you would maybe amp up coverage is if you had a Pseudomonas concern. For people with Pseudomonas concerns, you really have to look at past medical history. So were they in the hospital 2 weeks ago? Well, I would maybe get concerned that they might have some Pseudomonas exposure. MRSA possibly as well. In my line of work in the emergency department, or I'm usually dealing with the initial encounter. So we're usually going broad and then leaving it up to the hospital team to taper it down. So you start maybe with somebody who comes in, they have a bad pneumonia, they were in the hospital 2 weeks ago. You might want to err on the side of more aggressive. Or you might say, well, actually I don't want to be. I want to treat them with ceftriaxone and azithromycin and call it a day. There's not a right answer there specifically, but technically if somebody did have hospital exposure really recently like that, and some people say even up to 90 days in the past, you would still consider them possibly exposed to one of these more resistant problematic pathogens. So again, that gets a little tricky. There's not really a right way to do that, but it certainly depends maybe on how severely ill the person is. If they're septic, you may want to consider more aggressive therapy. If they're doing okay overall, you might want to consider something a little bit more standard. So it's a bit of a provider decision there. For HAP-VAP, this isn't quite as confusing. Usually if somebody develops this, you're just going to treat them broadly right away. Vancomycin, vancomycin, metronidazole, covering everything. Whether you need to cover anaerobes or not is probably situational. Where I would recommend thinking about anaerobic coverage when it comes to respiratory infections is for aspiration pneumonia. So if somebody has aspirated, which certainly is possible with a ventilated patient, that's where you want to cover anaerobic pathogens. And that applies to any type of pneumonia, but specifically HAP or VAP is where you might see that more commonly. One other thing I should say, double covering Pseudomonas. It is generally recommended that in some populations you double cover Pseudomonas. There is some controversy over whether it's worth doing this or not, but a really common example would be like if you had vanco and zosyn as your primary regimen, you'd add ciprofloxacin onto that as well. COPD exacerbations are kind of like a mini cap. They're not as broad spectrum. Generally, they use just like the cephalosporin alone, azithromycin alone, sometimes doxycycline. There's not a lot of good evidence for which one of these does anything, but usually it's just a single antibiotic and a shorter course than what you treat CAP with. Here's some other information I don't really care you know, just there for fun. I mean, I care that you know it, but I'm not going to test you on it. How's that? All right, cardiac. Endocarditis. Endocarditis is kind of complicated, so I'm gonna blow through it fast because it's not something that you'll probably deal with on a regular basis. It's a little more rare. Basically, what we've got is an infection in the inner lining of the heart. Usually, what I see this is the IV drug users. It's a more common presentation. Dental procedures, possibly. People at higher risk, they prophylax. You'll see that if you're reviewing patient medication lists in your career, you're going to see people who are on prophylactic antibiotics prior to dental procedures. So they take like a dose of amoxicillin before they go in, and that hopefully helps. Newsflash, studies say it doesn't, but they do it anyway. So, but IV drug users is going to be the biggest population in like a big metro area where you're going to see people coming in with infectious endocarditis. So again, here's a picture of what this looks like in case you're curious. Sorry. I like my funny pictures in my diagrams, even though sometimes they're a little silly. All right, so mostly caused by gram-positive bacteria. You're looking at strep viridans or Staph aureus. 10% of cases will be kind of a mixed bag of stuff, which I've listed here. Don't really care, you know that. And this is going to be a long treatment course. Usually if the valve is prosthetic versus a native valve, you're going to treat longer than that. Usually the nice and not nice thing about this is that because this person has bacteria growing in their heart, that bacteria is getting thrown all over the body because obviously blood's pumping through there. So you're going to see blood cultures come back positive, which is going to, one, give you the nice part of this, right, is it gives you a key into what you're actually treating, so you can narrow your therapy appropriately. The not nice thing about that is that bacteria can seed elsewhere and cause all kinds of issues. So endocarditis is pretty serious. We treat it pretty aggressively with with antibiotics, and then things like procedural solutions are going to be helpful as well. So whether somebody needs a valve replacement or something like that, that's not my cup of tea, but certainly that's an option, and sometimes people are going to go down that route. Here's some of the antibiotics we might use for it, just for the different ones. Usually we're looking at some kind of like vanco, ceftriaxone type combo. Sometimes for the prosthetic valves, they use rifampin. Rifampin is kind of an oddball. I don't mention it very often, but I might as well talk about it because it's here. That's going to be, it's actually a tuberculosis medication, but it does have some interesting ability to help with synergy when it comes to biofilm penetration. So if you have issues where you have like a really thick vegetation of bacteria growing over something, like in a valve case here, it can help with that. And so with prosthetics, that sometimes is used in that particular situation. It's never used by itself. Rifampin by itself doesn't really do all that much. You have to have it synergistically, usually with vancomycin plus like an aminoglycoside or something else. CNS. Bacterial meningitis is a quite dangerous situation to be in. It's highly fatal if you don't treat it. What you're going to do pretty much immediately if you suspect it is you're going to get cerebral spinal fluid and blood cultures right away, and you're going to look at the CSF findings. So usually in a person with bacterial meningitis, actually bacterial, not viral, bacterial meningitis, you're going to see glucose is going to be low, protein is going to be a little higher, and white blood cell counts usually going to be elevated too. Not an absolute diagnostic criteria, but it's pretty good. I always remember this, that like if there's bacteria in your central nervous system, they're eating sugar, so your sugar is going to be low, and they're creating waste products and byproducts and things like that, which is why the proteins are going to be higher. Now, whether that's true or not, I don't know, but that's how I remember it. So take it for what you will. Antibiotics, you're going to start those right away. Dosing is higher than standard infections, and CNS penetration is quite important for this. So obviously you want your drug to get to the site of action. This is a slide that shows you what types of bacterial pathogens are used and then what type of antimicrobial therapy lines up with that. Oh my gosh, this thing really wants me to restart, doesn't it? The thing to remember for this class, and what I want you to know for the exam, is that for basically anybody other than little tiny kids, less than a month, we're going to use vancomycin and a third-gen cephalosporin. So you don't really even have to know any of this. I mean, you do, right? You want to know this, but if you want to really dumb down meningitis, vanco, ceftriaxone, call it a day. That's basically where you're going to start for the vast majority of your patients. Now, if they're over 50, you do that same course, but you also add ampicillin. Ampicillin covers listeria, which you see more commonly in older people and really, really young kids. So now, does these other drugs cover listeria as well? Yes, but you double cover it, and everything kind of gets double covered that way. And again, we're aggressive because this is a pretty serious infection. Now, if you have any type of trauma to the head, you're generally going to be expanding coverage to cover Pseudomonas, so that's cefepime. It's going to be the common one they use there. Meropenem as well for allergies would be a good option, especially if somebody has a bad cephalosporin allergy. I would go to meropenem. Remember, imipenem does not penetrate the central nervous system, and piperacillin does not penetrate the central nervous system. So zosyn, primaxin are not good options for meningitis. And just to review, if you are curious which ones match up with which, here's the list. The strep pneumo is double covered. All right, GI tract. Helicobacter pylori is our culprit of peptic ulcer disease. So somebody has an ulcer in their stomach, we're going to treat it with a course of antibiotics. Standard triple therapy is the common starting point, which includes amoxicillin and clarithromycin. Those are the two antibiotics. The third part is a proton pump inhibitor, which is a drug like Prilosec or Nexium, Protonix. Those are all going to work to decrease the production of stomach acid. And those three are the triple. If you have somebody, again, this always comes up, tons of patients have these allergies listed to beta-lactams. If they have an amoxicillin allergy or penicillin allergy, metronidazole is going to be your substitution. So metro plus clarithromycin. Quadruple therapy is usually used if somebody fails triple therapy. And metronidazole, tetracycline, PPI. So it's a similar course where you just have two antibiotics and your PPI. You add on Pepto-Bismol or bismuth subsolate, and that's going to give you kind of like a topical antimicrobial effect. The bismuth subsolate is actually a little bit of an antimicrobial in and of itself. These treatments aren't the greatest in the world. They have about a 20% first-time failure rate. Usually the general strategy, if you try triple therapy, if it doesn't work, try quadruple. You can confirm eradication with additional testing at each interval. If quadruple fails, then there's some levofloxacin-based regimens that are a little more complicated that I'm not going to get into, but there are other options to try. And here's a little guide in case you want to look at a chart. Intra-abdominal infections. This chart looks kind of complicated, but I think it's relatively basic. You're looking at community-acquired infections. We're going to focus on adults here, although it's quite similar between kids and adults. For anything mild to moderate, you're basically just covering E. coli and Bacteroides. So you want something with decent gram-negative coverage, anaerobic coverage, and nothing really else. That's what you're looking at. So a lot of times what we'll do is a cephalosporin, ceftriaxone, plus metronidazole. It's a cheap, easy way to do it. You can do combination products, like you could do ertapenem, which is easy, it's once a day, but it's expensive. You can use moxifloxacin, but again, these are all a little off the beaten path. So I always recommend ceftriaxone and metro for these types of things. If they want to do Cipro flagell, that's fine, but Cipro's E. coli coverage isn't as good as ceftriaxone, and it's usually got more side effects associated with it. So I always recommend ceftriaxone over Cipro in this case. Now, if somebody's high risk intra-abdominal infection might be like a ruptured appendix. That's a good example of something, or somebody who's really septic in addition to whatever's going on. That way, you're going to expand your antibiotic coverage. You're going to do something that covers not only this stuff, so remember your E. coli Bacteroides, but also, guess what? Our friend Pseudomonas comes back into play. So if you look at these drugs, what do they all have in common? Yeah, they cover Pseudomonas, and they cover anaerobes, and they cover most gram-negatives. So that's your general strategy for treatment. Now, these are extrabiliary complications. For biliary infections, it's like a cholecystitis, a little bit more basic right away, and then it moves on to basically become the exact same thing as what we just talked about. C. diff, or Clostridium difficile, is usually associated with healthcare exposure or antibiotic use, but there's actually some other drugs that it's getting more associated to, like just general suppression of your stomach acid. So taking a chronic proton pump inhibitor is associated with Clostridium difficile. We see some community cases too where people are like, I've never had this before. Why do I have this? And so there is some community transmission as well. It can be quite mild or cause really severe pseudomembranous colitis, leading to pretty profuse diarrhea and sometimes intestinal damage as well. You want to stop your offending antibiotic as soon as possible or change therapy. So here's some items that are less likely to be associated with C. diff. I think about anything with heavier gram-negative and anaerobic coverage. It's going to be more likely to wipe out the GI flora and put people at risk for C. diff infections. So Clostridium difficile is just kind of opportunistic, where if you wipe out other bacteria in the GI tract, it can kind of overgrow to a point where it becomes problematic. Antibiotic regimens, we're going to use vancomycin 4 times a day. That's our initial episode, whether it's severe or relapse. That's really the drug of choice. We used to use oral metronidazole first line. That's fallen out of favor. If the vanco doesn't work right away for the first course, you can increase the dose. You can change the treatment duration. Taper for what? I don't know. Actually, I think I left that blank intentionally. So with vanco, you'll see all kinds of things done with it, or with C. diff, you'll see all kinds of things done with the vanco dosing. People will do these really complicated long tapers. Usually these patients have tried multiple courses of vanco, and now they're at a point where they're trying to keep them on vanco to suppress the C. diff from growing, but you can't really do that for life. So eventually you want them off of it. So you kind of create these elaborate taper structures to get the person off really slowly, and hopefully that works. If that doesn't work, there's fidaxomicin, which can be used in vanco-resistant cases. IV metronidazole can be used as well. Probiotics, orally, they aren't going to hurt anything, but they haven't been proven to help at all. One thing that's been done is fecal transplant, where they actually take a stool sample from usually a relative or somebody you live with, and I think they I don't know exactly what they do with it, but I think they encapsulate it somehow so you can ingest it, and then you're literally transplanting stool, and that's actually proven to be pretty effective, and I believe that was invented in Duluth, Minnesota, so that's the claim to fame up there. Not Lake Superior and the beautiful scenery, but fecal transplant. The one thing I want to point out is people tend to get this confused kind of the first time they hear this. This is really important. This is an oral only option. So vancomycin, I think about vancomycin as 2 different things. So you have vancomycin IV, which systemically works when given in an intravenous infusion, right? It doesn't really get into the GI tract via IV. It stays pretty much in the body. It's a big molecule, so it doesn't absorb. And so that's why when you take it orally, it basically just has a topical effect. It stays within the gut. It doesn't get absorbed systemically. So you can't give vancomycin PO for systemic infections. So if you're like, oh, this person's on vanco inpatient. Oh, I remember Chad talking about vancomycin PO for C. diff. Can we use that for their pneumonia? No, that doesn't work that way. Other enteric pathogens, Salmonella, Shigella, Campylobacter, E. coli, these are all things that will pop up on stool cultures, and you'll see varying ways that these are treated. Basically, a few of them are self-limiting. Shigella is something you would treat right away with fluoroquinolones. If anything is really substantial or causing fevers or bloody diarrhea or putting somebody in the hospital, of course, you're probably going to want to treat it more aggressively with an antibiotic. E. coli, especially if it's an enterohemorrhagic strain, which is the EHEC or the 0157 isolate, that is a Shiga toxin producing, which is a little complicated or confusing because it's not Shigella, that's E. coli that actually is Shiga toxin producing. And you actually don't use antibiotics for this because it can lyse the bacterial cell, release toxin, and cause more significant damage than what you've got going already. Standard E. coli, not the enterohemorrhagic strain, is what people usually get when they get traveler's diarrhea, and Cipro covers that pretty well. It's really easy to remember this because you either use Cipro or macrolide, and those are going to work for basically all of these, so you don't really have to think about it too hard what you're going to treat them with. GU, uncomplicated UTIs. First of all, we want to assess, are they getting dysuria, increased urinary frequency? Elderly patients might not have those symptoms. They might present with more of an altered mental status picture. Flank pain, fever, usually indicative of more of a systemic infection, pyelonephritis, treated a little bit differently. Remember not to treat asymptomatic bacteriuria. It's not recommended to treat it, with the exception of a couple people. So pregnant patients undergoing traumatic urological interventions, and people just if you deem somebody high risk. But for the most part, you aren't going to treat this. So if you culture somebody's urine, it grows bacteria, and they didn't have any symptoms, don't give them an antibiotic. And that is where it gets a little confusing. So contamination, colonization is infection. An example I gave here, long-term catheterized patients are usually going to have some kind of a bacteria growing. Usually it's not something we care too much about because they're simply colonized with it. It's not causing an active infection. And then I bolded E. coli because it's the most common one you're going to see in UTIs. 90% will probably be caused by E. coli. The other ones that might cause it are Klebsiella, Proteus, and Staph saprophyticus. Fortunately, they're all treated relatively the same way empirically. The two bold options are the ones that are recommended to use the most because they cover E. coli better than the other ones. Nitrofurantoin, 100 milligrams twice a day for 5 to 7 days. Now, just because this is bolded, again, I don't want you to remember this dose. This isn't one I care about, but just so you know. Unfortunately, Bactrim and Cipro, you can get away with really short courses for an uncomplicated UTI, but their coverage for E. coli is about 80%. And so Bactrim might even be a little lower than that. Cipro might be a little higher than that, but about 80% for both of them. And so they just aren't as good empirically as nitrofurantoin, which has like a 95% E. coli coverage rate, and cephalexin, which has like a 92 or something. So significantly better odds of catching the bug the first time with these two drugs versus 1 in 5 patients you prescribe Bactrim to for a UTI will have to get a new antibiotic, and that's not acceptable rates. If those don't work, or if the first drug comes back resistant, follow your culture data, culture the urine, see what else is susceptible, switch them. I think Bactrim and Cipro are great options for second line once you have the culture data, if it's susceptible to Bactrim or Cipro, to be able to give that to them as a 3-day course. It's convenient, but you really want to know for sure if it's going to work first. So that'd be a case where you prescribe cephalexin, comes back, cephalosporins are resistant, but Bactrim's susceptible. All right, let's switch them to Bactrim. Follow the cultures, adjust as you need to. 2nd, 3rd generation cephalosporins in resistant cases. Pregnancy, macrolide or cephalexin are good choices. Remember, beta-lactams are always a good choice in pregnancy. Complicated UTIs, if the patient is male, they're pregnant, they have a chronic catheterization, those are kind of some of the complicated criteria. Usually you're just going to do a longer course of treatment and sometimes higher doses, and generally not using nitrofurantoin. You can use nitrofurantoin in a pinch. With male patients, be careful because Sometimes there's a prostatitis at the same time causing the urinary tract symptoms, and it's hard to diagnose that. So you might not be able to know that for sure. And if you give macrolide, it's probably not going to penetrate very well into the prostate tissue. It's just going to stay in the bladder and the urinary tract. So you might not actually treat the underlying source. So for male patients, we're usually using Cipro. That's going to be the more common choice. Even though the E. coli coverage isn't great, I get that, but there isn't a better option. Or you could use maybe a more advanced generation cephalosporin. But cephalosporins also don't penetrate tissues quite as well as fluoroquinolones do. So fluoroquinolones will get to the prostate better than a cephalosporin will. For pyelonephritis, again, kind of the fluoroquinolone becomes the first line. So we use levofloxacin or ciprofloxacin, and it's because our macrolide and beta-lactams generally have poor kidney penetration. You can use a beta-lactam, you just have to do a more extended course and a bit of a higher dose than you would for an uncomplicated UTI. If somebody's pregnant, basically just going to stick to the cephalosporins and usually use higher generations to make sure you're going to catch that E. coli. In case you're wondering, a second or third generation cephalosporin like ceftriaxone, ceftriaxone, those have like a 98% coverage rate of E. coli, so it's almost a sure thing that it's going to work. All right, STDs. This is a propaganda poster I found, just something from the World War II era, I think, and yeah, encouraging people not to spread STDs around. So this is one case where I actually do want you to know the dose. So I repeat, know these doses. Chlamydia is treated with azithromycin 1 gram once daily, or 1 dose. Gonorrhea is ceftriaxone, 250 IM times 1 dose. Plus, you want to treat with azithromycin. So somebody comes with suspected STD exposure or STD symptoms, you're basically always going to just treat them empirically for both of these things, especially because it's very difficult on an assessment to differentiate between the two. You can get a screening in a culture, but you aren't going to get that back for a few days. So it's always best, in my opinion, just to treat right away and don't worry about it. It's a one-time dose for both options, and it's highly effective at clearing the infection. There's very little downside to doing it. So again, I highly, highly recommend if you're suspecting an STD, don't wait for the culture, just treat it. Because the odds of you getting a hold of the patient after they've left your environment is like, I don't know, let's say 50%, maybe. It's not good. So that's something you probably don't want, somebody who, oh, this person tests positive for chlamydia and gonorrhea and I elected not to treat them and now I can't get a hold of them and they're out there in the community and they don't know and there's no way to let them know. That's a situation you don't want to be in. And believe me, it happens. So certainly if you're suspecting that, go ahead and treat. You will get the patient in there that has somewhat obvious symptoms, but then they deny any type of sexual contact or whatever it might be. That can be hard to navigate, but if you have somebody who's a little more obvious, then certainly treat them. Trichomoniasis is a parasite that is treated with metronidazole, so that can be an option to add on for female patients. Male patients usually can transmit it, but it's not something we generally treat empirically in male patients. You might see it come back on a culture, which then you'd want to treat, but it's rare. Bacterial vaginosis is not STD specifically, but can be, which is why I listed it here. And there's a bacteria called Gardnerella, which is treated with metronidazole, and that's either an oral course for 7 days or topically Metrogel. So for a pregnant patient with bacterial vaginosis, Metrogel is a really good option because it doesn't absorb systemically. There's very little risk to the fetus. Syphilis is a tricky one. It's got a multiple week incubation period. It starts with what's called a chancre ulceration at the site of infection, which is supposedly kind of like a painless blister. It can be easily visible, like on the surface skin of the penis, for example, or it could be internal inside the vagina or inside the anus or somewhere where a person wouldn't see it. So that can be a tricky part in identifying it. The bacteria, by the time the chancre is available, the bacteria is pretty much widely disseminated. And then somebody's moving into secondary syphilis relatively quickly, weeks to months after that. Then they get a nickel and dime rash over time as the spirochete sort of makes its way through the body. And then people will start to get progressively more severe secondary symptoms, alopecia, musculoskeletal pains, and then starting to develop neurologic symptoms, which leads into late stage or tertiary syphilis, which is cardiovascular involvement, neurosyphilis as well. Oh, I should probably say this Al Capone, he died of syphilis. That's why there's a picture of him here, in case you didn't know that. Syphilis is a spirochete. I found this really cute picture online of a spirochete. Yeah, stuffed one. There's actually some website that makes these. They're like stuffed bacteria. They all have like little cute eyes and stuff like that, but kind of like Pokemon more so than a gross bacteria. But there you go. The fortunate thing about syphilis, even though it's a little bit complicated and can be pretty devastating if you don't treat it, is it's really easy to treat. So penicillin is the basic treatment. One-time dose of penicillin, 2.4 million units IM, and that should treat early syphilis. Latent or unknown duration, repeat every week for 3 weeks, so basically 3 shots, and that should be fine. If penicillin is not an option due to allergies, there are some other choices, but these are frowned upon. We don't really know. We aren't as familiar with non-penicillin medications for syphilis. And usually if somebody has syphilis and they have an intolerance to penicillin, a lot of times they'll actually desensitize the patient to penicillin instead of treating them with an alternate. For advanced syphilis, we want to use the same as the latent option, but we're going to treat it a little more aggressively, usually using IV penicillin at high doses and doing it that way. Now, in this case, you're definitely going to want to desensitize the patient because there's really not a documented alternative. Now, do other things cover spirochetes? Probably, but again, we know penicillin works, and so that's where we go with it. Sepsis and bacteremia. Sepsis can be caused by any source of infection. A lot of people think you have to have a bacteremia to be septic, and that's not true. You can have a sepsis case from pulmonary, urinary, whatever infection you want to name. You could be septic from it. Bacteremia just means that you have bacteria in the blood. No, the two can go hand in hand, and usually you're going to treat broad spectrum for either one. But just to point that out. Sepsis, you have to meet some criteria. So you have to meet SIRS criteria, which is systemic inflammatory. Why am I blanking on the R? Let's just say systemic inflammation. That's an easy way to think about it. Temperature elevated, respiratory rate elevated, heart rate elevated, white blood cell count elevated. And then to make it sepsis, you have to have a confirmed or suspected infection. So there has to be some sort of evidence that leads you to believe that the person's having an infection in some part of their body. Once you get to severe sepsis or septic shock, that's where you have end organ damage and hypotension. And then the further on you get is hypotension that doesn't respond to fluid boluses, and that's where you get septic shock. So sepsis, we're going to talk about that more next summer when we talk about emergency medicine and critical care a little bit more, but the idea is that it's really serious. You treat it aggressively and you treat it right away. Get your blood cultures and start your antibiotics right away. It's sort of like a shoot first, ask questions later. You want to give really broad coverage, and then you can always pull it back at a later time. Some other things that I just want to mention quickly. Tuberculosis, I won't test you on TB at all. Just know that there are drug regimens out there that are months to take. Usually you go to places to get the medication and they actually watch you take it. It's called directly observed therapy, which is really rare in the medical world, but it's done for TB. There's a lot of other drugs that could be used, but there's resistant cases as well. So that's all I'm going to talk about with TB. It's much more of a specialty thing. It's not something you'll probably deal with unless you work in travel medicine or international medicine. And then you get really familiar with it, but this is all I really want to talk about for now. Lyme is, on the other hand, really commonly seen, especially in Minnesota. I think we've all probably seen this at a biology class of some kind, the tick cycle and how it spreads Lyme disease. Lyme disease has a progression that's very similar to syphilis. It's a spirochete. It's called Borrelia burgdorferi, and it's treated primarily with doxycycline. So that's where with syphilis, we're like, doxy probably works just fine for syphilis, but again, we use penicillin for that. We use doxy for this. Lyme disease can, again, just like syphilis, get into the musculoskeletal system and the neurologic system as well. So you can end up with complicated diagnoses over time. Complicated diseases over time. The diagnosis of it's a little bit complicated too. There's different pathways that it goes down to figure out, like, do you actually have this or not? And I should point out that syphilis is the same way. The labs for syphilis are really complicated to review. I recommend getting an infectious disease person involved if you're trying to get a Lyme confirmed diagnosis or a syphilis confirmed diagnosis. Advanced disease with Lyme. So what Lyme starts with is the erythema migrans, which is kind of like this target symbol, but some people don't get it, or they never notice that they actually got it. That's sort of the first stage. The next stages of Lyme become neurologic and cardio-related, arthritis. Basically, if somebody has less serious Lyme or early onset Lyme, you're going to treat with doxycycline. If it's more serious, we actually use ceftriaxone. Doxy does come as an IV form, but again, they use ceftriaxone because it works well. It gets into the central nervous system really well, which is a good way to treat neurologic complications. Ehrlichiosis is another tick-borne illness that looks a lot like Lyme. It's treated basically the same way, but it's slightly different. Chronic Lyme disease is something that comes up occasionally. Chronic Lyme disease is, from what I understand, quite controversial. From what I've read, it's not really well known. I think from what I understand, the infectious disease community generally doesn't think that chronic Lyme is a thing. Basically, you take antibiotics, it wipes out the bacteria, and then whatever residual symptoms you have is because there was some damage done. So if you've had neurologic damage or musculoskeletal damage, that's going to take time to heal, or may in some cases never heal. So it's not like you still have a chronic infection going on, but there is a school of thought out there that says that the spirochete stays in your system for a while, and the Lyme, or the Borrelia, continually infects you. And so some people out there with quote-unquote chronic Lyme disease are taking cycles of antibiotics on a regular basis to prevent this. There are some physicians out there that prescribe this. It's generally thought to be a little bit fringe medicine, and definitely not studied. There's no evidence that it does anything. And but there are people out there that swear that this is truth. There are lots of people that disagree with that. So I'll leave it at that. That's all I've got for this lecture. All I've got, you're like, oh, that's a lot. Yeah. So just for the exam purposes, this is a really big chunk of material for the exam. I really want you to be well versed in bacterial infections. So we'll talk about a couple other things like antivirals and antifungals as well. But from an ID perspective, this lecture and series of slides is the substantial component that we're going to be talking about and using for exam material.